It was a very long uh, thing you have told about me. I'm so grateful. So I'll start my lecture with the gratitude to Sun Pharma, Mr. Naveen Kaul, Mr. Mahinder Verma, Mr. Ranjit. Thank you very much for bringing me on board and uh, making me share my views about Meniere's disease. I have been practicing vertigo for the last about 20 years since the time I started cochlear implants. It was my passion about the inner ear which made me do both the things, implants and vertigo. Uh, we all know Meniere's disease is a very underdiagnosed problem. Uh, and before I start, I welcome all the people in the audience. My gratitude, my thanks to you for coming and getting switched in. Uh, we all know that Meniere's disease we call when, as Prosper Meniere's told us about more than 100 years back, uh, when there is a triad of symptoms of tinnitus, hearing loss, and vertigo. And when the cause of the disease is not known, we call it Meniere's disease or idiopathic endolymphatic hydrops. Whereas when the cause is known, we call it a Meniere's syndrome. But what Professor Meniere's told us, in between the classical picture and the prodromal stages when the disease begins, there is a lot to be discussed about and what we miss at times when patient comes and tells us about those symptoms. And fullness in the ear and oral pressure is one of those two simple symptoms which people come and tell us, and we many a times all of us overlook. And today my aim of this lecture would be to identify what is the endolymphatic structure, how the endolymph is formed, where exactly the problem occurs, and how does it produce symptoms, and how do we treat that. That is my whole crux of the lecture, and I hope, and by the end of the thing, we all interact and learn from each other more about what this disease is all about. Now, the most important thing is that it is much before the Meniere's disease per se comes into picture. It has already started producing a damaging effect on the ear. And the most damaging part occurs in the first few months, year, and the first few years, depending upon how severe the infection the process in the ear starts. So as simple as oral pressure, deep-seated ear pain, burning sensation, hyperacusis, people coming and telling us that whenever they are exposed to sound, it irritates them, particularly the higher frequencies and others. It is quite irritating. Tinnitus, hearing loss, Tullio phenomena, not exactly Tullio phenomena. The patient would come and tell you, sir, the moment I put my finger inside to clean the ear, I get some dizziness. Now, many a times we do overlook this phenomena. If we see the eardrum and everything normal, maybe we get a CT done, an impedance done, the tympanometry is also fine, the CT is also fine, and our mind would not go into something brewing in there, which may come and become manifest as Meniere's disease later on in life. And then comes the vertigo finally. But again, I'm telling you, there are many, many vague symptoms. There may not be people who would classically come with these kind of situations, these kind of symptoms. And there are vague symptoms. I remember I had a lady who said, Dr. Saab, I don't know what is happening to me. There is a funny kind of heaviness on this side of the ear. I'm irritable always. I don't know what is happening in my brain. And to the extent that I've been suffering for the last 6 to 8 months, I've gone, people have given me all kinds of treatment, and I am now thinking of committing suicide. Believe me, this was the situation when she came to me, and when we diagnosed her, and what came out, I was really surprised. So that means now we divide all these conditions into 3 major portions. Either we call it atypical Meniere's, if we have to call it Meniere's, we call it endolymphatic hydrops, and more than that, we call it cochlear or vestibular Meniere's or hydrops. And now, as we go into the anatomy and physiology of the inner ear, I'll tell you that how this is all happening. We also have staged the Meniere's disease into the 3 stages. The first stage, stage 0, the prodromic stage. As we all know nowadays in COVID also, the disease is infective much before the patient starts to show the symptoms. And exactly, particularly in every disease, we have these kind of things. We have an impending viral fever coming. Before that, we have a malaise, weakness, and all those things. In prodromic stage of Meniere's, this is what is happening. So the patient may come to us with all the symptoms I have told you in the earlier slide, and it may also be very vague, sometimes so vague that you start thinking of sending them to a psychological assessment. The second stage is divided into 2. Stage 1, the fluctuating stage, and the disabling stage. The fluctuating stage is the one in which you have fluctuation of hearing losses, you have vertigo, disabling tinnitus, and all these things. And these are fluctuating. It might become better. It comes, remains for a few days, hours at times, and then goes away, but it keeps fluctuating. And then comes the disabling stage. That means now the hearing loss has become permanent. The vertigo is also now becoming a little more stabilized, and the tinnitus is increasing. So that is what we call the 1B, the disabling stage. Stage 2 is the stabilized stage. Many of the patients would come to us at this stage. And in the stabilized stage, what happens is the patient comes to us and says, "Doctor, I'm very irritated by the tinnitus which is coming. It doesn't let me sleep. It doesn't let me work. And I'm very, very irritated about it." You ask him about hearing loss and he says, "Yes, maybe, sir, I have some hearing loss, but I'm not bothered about it. But there is some hearing loss, but I can do with whatever hearing loss I have no problem. Please, you do something about the tinnitus." Then you ask him about the vertigo and he'll say, "Yeah, I got an attack a couple of months back. 1 or 2 remained for a few days. It was more of an imbalance, but now I'm not having that problem. And I think that probably that also because I ate something very bad and I had a bad stomach, and that probably was because of the bad stomach I had. So I'm not bothered about that vertigo which was there." But as a surgeon, as a ENT specialist, you will have to bring these all symptoms together and now think that probably this is a case of stabilized stage of Meniere's, where probably the endolymph has completely filled up the sac inside the membranous sac. The fluctuation of the endolymph inside the sac is not occurring anymore, and you have a sense of imbalance, maybe not that also, and everything has been stabilized. It is only the tinnitus which is causing a problem to the patient. Yes, you get an investigation done and you will find that the problem is there. The stage 3 is the contralateral ear stage. About 50% of the patients after the first attack or the second attack, or maybe sometimes the third attack, will even start having the problem in the other ear, and 50% go into that, and this is called the stage 3. Yes, please understand, it is not always like that you will get stage by stage the problem. It can start as a bilateral disease. It can come as a stabilized stage. I told you the patient might come to you with only irritable tinnitus and nothing else, and you have to dig out what the patient has the problem inside. Now, before we actually go into what this is all about, I will take you back to this picture of the endolymphatic system. Please understand the dark green is the endolymph and the light green is the perilymph. So you have a bony structure outside, the bony otic capsule, in which you have perilymph, and inside that is a balloon floating, which is called the membranous labyrinth, and inside that you have the endolymph. Now, this is divided into 2. The pars inferior, which is gravitationally down, and the pars superior. But not only that, it is not that it is just the gravity or superior or inferior structures. They have their own identity also. The cochlear duct comes and joins the saccule, and there is a small little saccular duct here which comes and joins, and then they go into the endolymphatic sinus. The upper portion, this is the pars inferior, and the pars superior has the utricle, that is the utricle, which also harbors the otolith system, the ampulla and the semicircular canals. We all know that this is then connected by a utricle duct into the endolymphatic sinus which we have before the endolymphatic duct starts and goes and ends into the endolymphatic sac. Now, the endolymphatic sac is an extradural intracranial sac lying there inside the head. It is extradural and intracranial. So that means whenever you jump or do something, there is all possibility that it might get compressed in that situation. And when you will do a cochlear implant, you will see, particularly in a child with large vestibular aqueduct syndrome, you will have a pulsating discharge for a little while. It is because of this thing opening up, the endolymphatic system opening up when you're doing a cochleostomy or even doing a round window insertion. The endolymph passes off in pulsating manner. It is because the dura compresses the endolymphatic sac and the endolymph comes out of that only for a little while. I would also like to tell you about the perilymphatic system here. The perilymphatic system is connected by the cochlear aqueduct. This was the vestibular aqueduct, and that is the cochlear aqueduct which connects it to the subarachnoid space where the CSF is. So that means when you do a cochlear implant and you have a gusher, a CSF gusher, that means it is a large cochlear aqueduct. And when you have a little bit of few drops of pulsating discharge coming out, that is the endolymphatic duct. Now, another important thing is that in the utricular duct, you have a valve, which is called the valve of Bast, B-A-S-T. Now, that is important. See, you don't have a valve here because this is already a dependent endolymph. Nature probably doesn't want the utricles, which are the otoliths which are there in the utricle, to come down into this system and block the system here, the endolymphatic duct, etc. So probably nature created the utricular duct with the valve of Bast, and so that also differentiates the pars inferior from the pars superior. So most of the time, the endolymphatic hydrop starts in the pars inferior region. That means you'll have a cochlear duct hydrops and a saccular hydrops. Now, what is the importance of an endolymphatic sinus here? Please understand that it is hypothetical. Even now, people have not been able to understand. Maybe it is a sac before the endolymph goes into the endolymphatic duct and into the sac. It is a small little retaining area so that everything doesn't just go there. Maybe some potassium from the endolymph gets absorbed here and then goes into the sac before it is finally taken off by the walls of the endolymphatic sac. The second possibility which may be there is that when you jump and there is some squeezing of the compression onto the endolymphatic sac, some endolymph regurges back, and so that it doesn't go into the cochlear duct and into the other areas where the endolymph is absolutely normal, you should not have no mixing of the regurgitated endolymph in this. Maybe it retains, the endolymphatic sinus retains that regurgitated endolymph from the sac when you are jumping and doing all that. And this may be one of the situations which this is fulfilling, the endolymphatic sinus. But the most important part is the valve of Bast in the utricular duct before it joins these things, so that none of those displaced otoliths can come into this area and remains in the ampulla or in the semicircular canal if they are displaced, or otherwise it remains in the utricle part only. So please, I hope if you understand, so that we can go about now and discussing the whole thing. Please understand that how is the endolymph formed in the endolymphatic system? There are two ways. One is the radial flow and the other is the longitudinal flow. The radial flow means it is formed in the stria vascularis. It is formed in the stria vascularis, and then the stria vascularis has two kind of cells: the dark cells and the light cells. The dark cells are the secreting cells and the light cells are the absorbing cells. So it forms in the stria vascularis and goes back into the stria vascularis by these two different kind of cells. And if there is something wrong, if there is congestion in this area because of any reason, what we are going to discuss, the endolymphatic formation becomes more. The Reissner membranes then bulges into the scala vestibuli, and the whole symptoms of tinnitus, hearing loss, maybe initially only tinnitus, but later on hearing loss also starts. But just because it is confined in the pars inferior initially, it may just restrict itself to these symptoms only of tinnitus and hearing loss, and the vertigo has still not come. The second way is the longitudinal flow. That means when it forms into the endolymphatic system, it then goes into the endolymphatic sinus, from there into the endolymphatic duct, and then into the sac, from where the walls of the sac behave as the alveolar kidney alveoli, from where the whole system is evolved. I would also like to mention here that we all know that the ear and the kidneys are both originate from the same germinal epithelium. So what goes wrong in the kidney also goes wrong in the ear. So if you have ototoxicity, it will also affect the kidney. It will also affect. So my further slides will tell you that how this thing which evolves from both evolving from the same germinal epithelium behave in a similar way as far as this is concerned. Now, if there is any problem which occurs in the longitudinal flow of the endolymph system, which is the duct and the sac absorptive functions, the most common cause of this is inflammatory debris. The inflammatory debris may be because of allergy, it may be because of autoimmune, or it may be even traumatic. You have a head injury, you have some inflammation inside the endolymphatic system because of the jerky movement of the endolymph inside the perilymph, and this trauma leads to some inflammation in the membranous labyrinth, leading to some inflammatory cells, which then block the longitudinal flow of the endolymphatic duct. The other things which can lead to the kinking of the endolymphatic duct are mastoid hypocellularity, as in sclerotic mastoids, hypodeveloped Trotman's triangle, anteriorly displaced lateral sinus. All these things can kink the endolymphatic duct passing through the aqueduct, and thus lead to absorption problems, leading to increased formation because of longitudinal flow. Now, what happens? How does this increase there? The formation and excretion dyssynchrony leads to the formation of endolymph, and that is happening either because of overabundantly produced endolymph or an inadequately absorbed endolymph. So either it is produced more or it is excreted less, or both. Please understand that. This slide is very important when you start treating. If you keep this in mind, your treatment modalities would be focused on this thing, and there is no way to know what is happening there. Only a postmortem can tell us that either there is a problem in the stria vascularis, or there is a problem in the endolymphatic duct and the sac, or it is both. So when we treat these situations, we have to keep that in mind, that probably both the things are happening. We cannot just treat the overabundantly production rather than the less excretion. So that we have to keep in mind. I've already told you that what is happening there. The pars inferior, that is the cochlea and the saccule, are the most commonly involved area in the inner ear. They are the most commonly involved. So what will happen is there will be bowing or rupture of the Reissner's membrane to the scala vestibuli, thus leading to the symptoms. Now you have a rupture of the tympanic membrane, for example, for any reason, and if you immediately treat it, not let it get infected, and not let water go into the ear, after some time it is an epithelium and it will heal very well and everything would come back to normal. Similarly, when this Reissner's membrane ruptures, the chances are that if you treat it immediately or spontaneously also, maybe it just went for any reason, we will discuss later what those reasons are, it just expanded, part of it bursted, You had some hearing loss. It again came back to normal, everything normal, no hearing loss, even the tinnitus. These things can happen. These are spontaneous recovery cases which can happen. The second thing which can happen in a pars inferior involvement of the saccule is the saccular distension. Please, as I was telling you here, the saccule is the one which is in close proximity to the stapes foot plate. And when you put your finger inside the extraordinary canal, you may have a dizzy spell. It is not amounting to Tullio's phenomena, not so severe so as to give you a typical nystagmus or something. It may just give you some imbalance, and that may be because of the saccular distension in the pars inferior. In the pars superior, that is the utricle, the common crus, the ampulla, and the semicircular canal. Now, please, this is important to understand what is happening. The herniation of the utricle into the common crus, that means this utricle can actually herniate into the common crus. Displacement of semicircular canal cupulae from the ampullar roof attachment. So the cupulae, as they're attached to the ampullar roof, may get pushed and displaced because of the endolymphatic hydrops, the utricular hydrops. I'll precise myself now only to the utricular hydrops. Please understand the valve of Bast probably is not letting the endolymph go out from here, the excess endolymph, and it is accumulating there, and that's pushing onto the cupulas and displacing them. Another thing which can happen is misplacement of the otoliths from the utricle. Now, we all know that the utricle has these otoliths, which not only get disturbed with things like head injury and other otological things we are doing, like surgeries or stapes or whatever. This can get into the semicircular canal or the ampullas and lead to a situation which is something like a benign paroxysmal positional vertigo. So just imagine you have something undergoing in the form of an endolymphatic hydrops, which has now produced a benign paroxysmal positional vertigo situation. So I'll talk about this, what happens. And the valve of Bast is the one in the utricle duct which stops the flow of otoliths in between the two compartments. The otolith should not go down here because then it will be a problem. You cannot reposit the otoliths which have come here back into the utricle, but definitely in the semicircular canals, the repositioning exercise is what we have. We can, by that, we can reposition the utricles back into the otoliths back into the utricle, and it is possible. So probably, as I was telling you, the valve of Bast doesn't allow the otoliths to go into the pars inferior, and that's how it saves that to happen. So this is what the anatomy and physiology was all about. Now we will come to the causes of the endolymphatic hydrops Meniere's disease system. One of the factors is genetic and familial. We'll just talk about the gene. It could be viral. It could be allergic, very important, and it could be autoimmune. It could be metabolic. Thyroid is a very big factor. Hormonal. I remember when I was a young boy, just starting ENT, I was told that it is the menopausal stress which leads to the Meniere's disease coming in women. It is definitely more in women, and it is probably the high estrogen level or the hormonal stress during what we call during the menopause that leads to the formation of Meniere's disease or endolymphatic hydrops. It could be vascular, ischemia. We all know that hyperlipidemia is one of the causes, and atherosclerosis of the vessels of the inner ear may lead to ischemia, thus leading to engorgement of the stria vascularis, leading to formation of more endolymph. So the endolymph is formed more, it is not excreted out via the light cells in the stria vascularis. Environment has a very important role, and that's the reason why now we are having young boys and girls stressed because of their jobs, leading to having symptoms of endolymphatic hydrops. And now, why stress? We all know that the renal artery undergoes vasoconstriction in cases of stress, and there is those problems of renal in cases of stress, increased salt intake. So again, I'll tell you that just because the ear and the kidney, they form from the same epithelial system, germinal epithelium. It is the same stress, increased salt intake and increased water intake, which are leading to the formation of more endolymph and causing the problems. So we have to keep in mind thinking of more young people now having endolymphatic hydrops or even Meniere's disease. The secondary endolymphatic hydrops can occur because of trauma, fractures in the region of the Trotman's triangle, whiplash injuries. Again, the leading to formation of the otoliths, otitis media, autosclerosis, intra-aortic canal lesions and masses. You would know that as the blood flow goes back via the intra-aortic canal into the venous supply returns, any tumor which is there can lead to engorgement of the stria vascularis because of the stasis of blood into the stria vascularis, thus leading. So indirectly, a small little mass in the intra-aortic canal can lead to a secondary endolymphatic hydrop formation. And that's the reason why we have to, when we are doing the investigations, we have to get that MRI done. Now, in genetic, 5 to 15% have genetic predisposition, and it is the mutation of this COC gene, the coagulation factor C homolog gene, DFNA9, which is an autosomal dominant, which may be one of the causes, as they say. Autoimmune is very important, and it has been seen that the human endolymphatic sac appears to be the primary immunocomponent structure in the inner ear. So it is a very immunocomponent structure, the endolymphatic sac, and that's the reason why the absorption in the endolymphatic sac is not as good, leading to the hydrops formation. It has also been seen that the endolymphatic sac can process antigen, synthesize antibodies, and raise a cellular immune response. The stromal cells inside that can lead to immunoglobulins A and G and secretory component formation. The perisaccular tissue contains macrophages, lymphocytes, and plasma cells, which also indicates toward autoimmunity. And antibodies against bovine 68 KDA, heat shock protein HSP70, are seen to be elevated in 50% of the patients of Meniere's disease. So this all indicates that probably autoimmune plays a very big role in cases of Meniere's disease. So we have to keep that in mind. We have to investigate the patient in those lines so that we can identify autoimmunity at an early stage and treat the patient accordingly. Now, once we have gone through the anatomy, physiology, and the functioning, how it happens, the most important is to diagnose, and I would still today say that history is the most important thing. The only thing is when we have in the prodromal stage that we need to do all these different investigations to confirm. But yes, they may not also give us, and sometimes I have started empirical treatment of endolymphatic hydrops, just going by what the patients have told me, and the patients have become all right. In audiometry, 60% will show a low frequency loss, and this is because the apex of the inner ear is more tightly wound. The chances of compression of the vessels there becomes more if there is an endolymph hydrops, and thus a high frequency loss. Please understand, a similar condition occurs, a similar thing can occur when there is a large vestibular aqueduct syndrome in a child. There, because of the regurge of the endolymph back into the endolymphatic system, there will be a high frequency hearing loss. There could be vertigo when the child is jumping, and a similar picture. The child may not be able to tell us about tinnitus, but that definitely also happens. So we have a typical triad which can happen in a child in large vestibular aqueduct syndrome. The difference between that in a Meniere's disease, most of the time the frequency loss is low frequency, and in a large vestibular aqueduct, because of the regurge from the endolymph back into the system, it's a high frequency loss which is more. But yes, we see a flat curve, we see a high frequency loss curve, falling curve, and this can also happen. Yeah, we can also have a normal audiometry, but still symptoms are there. Now, how to prove this? How to prove this is by CC. I don't know how many of you are doing this simple test in the audiometry room, the short increment sensitivity index, and this is very, very useful even in the early stage. I'll tell you how it happens. And complete vestibular assessment, and we are very fortunate to have neuroequilibrium lab in our setup, which helps us to pinpoint other diseases associated with Meniere's and treat them also simultaneously. So that's very important. But as far as CC is concerned, I would like to emphasize here that CC is like taking blood pressure. When a patient of blood pressure comes to you, the first thing you do is take the blood pressure and then regulate and readjust the medicines you give to the patient. And CC is also something like that. I have seen CC very high, and we give the treatment, the CC goes down, and the patient is also symptomatically much improved. So CC is a very small little test which can be done in any audiometry room, and it gives us an exact picture of what is happening inside the pressure inside the endolymphatic system. I would like to talk about something about CC a little more. It is a measure of the recruitment and is purely a condition of the hair cells and the nerve endings. Please understand, you won't have recruitment other places. The most important place is the hair cells. And recruitment is an exaggerated perception of sound. A small increase in the sound intensity seems much louder and distorted. So just imagine you are giving a sound which should be sensed like that sound, but it is going to the nuclei and to the higher centers as a potentiated response. Now, what happens is that the normal hair cells inside the cochlea, they are recruiting their adjoining damaged hair cells. So what damaged hair cells are present, which are not supposed to be doing any job now, and whether they are temporarily damaged or completely damaged, as we say, a temporary threshold shift and permanent threshold shift. So they are recruiting those damaged hair cells and asking them to do the job, so that when you give the sound sensation, this sensation becomes potentiated, and when it reaches the brainstem, it appears louder than what is supposed to be. And the CC results are, I can tell you, positive in the early stages. Please understand, in the early stages, it is positive in 2/3 of the cases. You try doing that, and you'll find it is a very beautiful tool to understand what is happening inside the endolymphatic system. We have this, as I told you, we have a very good setup here from the neuroequilibrium people in Jaipur. We have video nystagmography, we are doing VAMP, posturography, all these ECOG we are doing, but you will all know that ECOG gives us, there are a lot of false positive and false negative results with ECOG, and only 1/3 of the cases. Yes, if the CC is not high and the ECOG can give us something, it will help us, but otherwise these are not so important as far as in my opinion, the CC, the history, the audiometry are all important in diagnosing the disease of Meniere's disease. Now, associated disease. What these vestibular assessment helps us is to tell us about the associated diseases. A very big thing is the vestibular migraine. We all know that vestibular migraine is a central problem, whereas Meniere's disease is a peripheral problem, but they can coexist for the reason. I'll give you one example. Both migraine and endolymphatic eye drops could be allergic in nature. Some allergy which is causing migraine, and some allergy which is also causing endolymphatic eye drops and inflammation in the endolymphatic duct system, leading to an endolymphatic eye drops and a vestibular migraine. So this is what these complete vestibular assessment helps us in doing. It will give us that picture of the associated diseases, so that when we treat the patient in the form of, as a case of endolymphatic eye drops or Meniere's disease, we don't forget. I mean, many a times I've seen when we treat it, the patient feels much better, but he's not 100%. He still keeps saying, there is a little pain in that side of the head or somewhere in the head. I'm not comfortable. I'm much better, but I'm not comfortable. And if we diagnose with neuroequilibrium that this is probably a case of vestibular migraine, we will realize that if we treat that simultaneously also, the results become absolutely great. Similarly, benign paroxysmal, if the VNG can tell us which semicircular canal is involved as primary or even secondary to endolymphatic hydrops. I'll give you an example. Suppose if the injury led to some inflammatory response in the endolymphatic duct, and it's also led to otolithiasis. It led to the utricular otoliths dissipating in the semicircular canals and the ampulla. So you have a same disease, that is the head injury, leading to a benign paroxysmal position vertigo and an obstructive endolymphatic hydrops. So you have to treat both the conditions simultaneously. This may just become better with the repositioning exercises, and the endolymphatic hydrops has to be treated the way it is. Other tests, very important. You have to get the thyroid function test. You have to get the P ANCA and the C ANCA, particularly in bilateral cases, particularly in fulminating diseases in children, in young patients. There is all the chances that probably there is an autoimmune disorder undergoing, which is leading to that, rheumatoid arthritis, other things, and it will indicate more towards autoimmunity, and we will have to see that. HRCT and MRI are very important. We have to see for any tumor. We have to see any problems in the Trotman's triangle region, that is blocking the endolymphatic duct or the aqueduct, the vestibular aqueduct. So that can be seen. Or in a child, a CT will also tell you about a large vestibular aqueduct syndrome. So if a child comes to us with symptoms of vertigo and hearing loss, and you get a CT done, you will find a large vestibular aqueduct syndrome, one side or both sides, and that is a cause of progressive hearing loss in a child and vertigo. So that means a child who is born normally, but in the next few years, maybe by the 10 years of age, he loses complete hearing as he starts jumping. The endolymphatic sac between the dura and the cranium compressed, and the endolymph regurgitating back is one of the causes that the child is losing hearing gradually and then completely. So this can happen. So a CT and an MRI are very important. All the other things also, you have to have glucose, you have to have a lipid profile, you have to have kidney functions, all the tests, but these are very specific tests which have to be done to rule out any other associated symptom and problem. Now, coming to the management is very important, and many a times we are doing a little wrong treatment in that, and which I'd like to tell you. Drugs, I will elaborate more about drugs. Treating the cause, I told you, there could be thyroid, you treat that. There could be autoimmune, you treat that. There could be allergies, you identify and vaccinate and treat that. Menet's device, I have no faith. Somehow maybe it doesn't work with me, but surgical, we have stopped doing completely. Endolymphatic sac decompressions have not helped at all, because probably the disease, the problem was in the aqueduct, in the duct, endolymphatic duct, rather than the sac. And just to open up the sac is not the only thing which will help, and that's the reason why failure. There is a very important role of rehabilitation, particularly when these patients have stabilized. They have come to the second stage. Very important that we go, and Neuroequilibrium is opening a habilitation center here also in my clinic. And shortly we will be able to habilitate the dizziness, the leftover dizziness which these people have, to help them in central compensation of that little problem, the brain taking over, the cerebellum taking over the function of that irritated or hypofunctioning labyrinth, or a vestibular vestibulopathy, as we call it, a unilateral or a bilateral, depending upon how the disease was. Rehabilitation is very important. We have many patients who are waiting for this thing to open up. Psychotherapy, very important. You have to console these patients, allay their anxieties, because anxiety again is causing the whole problem to occur. Hearing aids, I have to say about a little hearing aids. Please understand that when you don't give a spectacle when the glaucoma is active, because the patient will be unhappy with that spectacle. Similarly, when the disease is on, the CC is high, the hyperacusis is there, you give hearing aids and the patient curses you. Please let the whole thing come down. Let the endolymphatic hydrops lower down a little bit. Let the CC come down. And then when you give hearing aid, whether as a hearing aid or as a tinnitus masker, they will really bless you. But when you start giving, a patient comes to you, he still has that problem active in the endolymphatic system, you give hearing aids to them, they are really going to curse you because they are very uncomfortable. The hyperacusis is actually driving them crazy with the hearing aid. The more they put the hearing aid, the more irritable they get. And they keep telling Dr. Hans, what did they give you? This is not suiting me at all, and I want to return it back to you. In the drugs, we all know beta-estine, beta-vert, a very good drug, particularly when the vertigo is on. But it also has a very good effect of increasing cochlear and vestibular and cerebral blood flow. So very important. But the only drawback is we cannot give it for very long, because if we give it for very long, we are not sure how the central compensation would act or come, and you stop it as early as possible. Give it for 10 days, 2 weeks, but after that, you stop it. Piracetam is a neurotransmitter. It has a vascular action. It reduces the erythrocyte adhesions, hinders vasospasm, improves microcirculation in the stria vascularis, and thus the increased formation is reduced and the less excretion is enhanced, and the patient tends to become normal. Diuretics have a very good role, and acetosolamide particularly acts on the endolymphatic sac walls and helps in absorption of the endolymph from that area. And last but not the least, the steroids. It is very important as an anti-allergic and anti-inflammatory, but in my clinic, I have about 3 centers where we give intratympanic decadron. That has a very good effect, because we all know it is a vasospasm inside the stria vascularis and other places. How much of this steroid would orally or injectable would get absorbed into the stria vascularis and go into the inner ear and help the situation is to be seen. My clinic, we give intratympanic. We have 3 in the clinic only where we give these injections, and 3 at a time we can give. We have very good microscopes and tables where we do. Now, what does intratympanic steroid do? It directly gets absorbed through the round window and goes inside the inner ear. It improves the vascularity, reduces inflammatory process in the labyrinth, restores normal functioning of the stria, regulates inner ear de novo protein synthesis, and improves the excretion also via the longitudinal flow, because it removes the inflammatory debris from the endolymphatic duct and thus leads to improvement of the whole situation. So that's very important. Intratympanic decadron. I'm not talking, this can be a separate topic to discuss how to give, how many to give, when to all give. I mean, I have even given it twice a day for continuously 5 days, and the results are very good. I've seen people giving it one stack or maybe 1 in a week. That doesn't help because the activity comes back to normal. We have to keep giving it for a long period of times, and the results are absolutely great. Believe you me, I have seen the CC going down. I get that. The CC is very high. You give 3 intratympanic decadron injections. The patient says, I'm much better, particularly in the initial 1 and 2 stages of the disease. And you get the CC done, the CC has come down. Very good effects. Yes, as far as gentamicin is concerned, I give intratympanic gentamicin only when there is the vertigo, but there is no useful hearing which is available in the cochlea. So that is the only time we give gentamicin. I don't keep gentamicin in my clinic. Every time there is a gentamicin to be given, I will request the patient to go and get it. And that is how I give, because I don't want to give gentamicin. It can lead to your hearing loss also. Intratympanic, I've told you, and this is a very good thing. I wish we all start giving intratympanic decadron more often. It is used in other conditions also. Sudden sensorineural hearing loss, viral or vascular, endolymphatic hydrops, Meniere's disease. It is tinnitus, acute tinnitus. Diagnosis may not be known, but it is a very good thing. Now the thought process, I'll take a little time for this thought process. Please try to see the vague symptoms. Patient is telling you, you getting an impedance done, the audiometry is normal, patient is very bad, you say there is nothing, maybe a PSY. Don't say that. Please try to find out, follow up the patient for some time. Maybe you can give some empirical treatment on the lines of endolymphatic hydrop. That doesn't really harm, but the patients become normal. Identify the routine symptoms as early as possible. It is a lifestyle disease. We have to reduce the salt intake. We have to reduce the stress. That's very important. Importance of CC, I have told you. Importance of intratympanic steroids, I have told you. And when to prescribe the hearing aids, I have told you. Please, that is very important. When it is stabilized, the hearing is stabilized, the CC has gone down, the active stage of the endolymphatic hydrops has gone down by treatment. That is the time when you give a hearing aid and also maybe a tinnitus masker along with that, and that will be greatly helpful. So that is what the thought process for today is all about. This is what I wanted to share with you, my experience in the last 20 years, and the results in my clinic are very good. Will you believe? There are days when I have to give 10 injections in a matter of 3 hours only. So there are three stations where I give, go to the other one, go to the other one. They lie down for 25 minutes. And this is how we have very good results. And that's the reason why people are coming back, because the treatment and the prognosis and the progress of the patient is very well. Thank you very much. Okay, I'll just go through that. Okay. Yeah, now there is one question. Do we have any specific test for autoimmunity in the form of double standard DNA, etc.? Yes, I think what I do is refer it to a endocrinologist. I have this blood collection center in my clinic, and I do for immunoglobulin study and P ANCA and C ANCA. And if it is not coming positive, and I clinically I feel, I refer the patient to endocrinologist, and they would see. This question was asked by okay, then are there any different types of sound coming in my right ear from the past 6 years continuously? Okay, there is a call from Amsterdam. What are the latest assessment procedures for Meniere's disease? I've told you, and it is very important that we go by these. Yes, history is very important. The CC, in my opinion, is very important. We do VAMP only in very early stages and in profound hearing loss to see which ear is active. VAMP is very important in that. And if suppose we have to give gentamicin injection, we get a VAMP test done to see which is the active side in a bilateral, because we can't do a CC in that. There is a question from Bucharest, Romania. Hello, is Tamarkan crisis, do you perform IT gentamicin? No, I don't. Gentamicin, I told you, I'm not very good at that. I will give it only in these conditions. There is a question from United Kingdom which says, what is the audiologist's role during rehabilitation of MD in India? No, there is a proper rehabilitation center we have in which there are specific technicians which do this test on machines. There is no audiologist role in this, but there are different technicians which are trained in rehabilitation and they do it on machines. There is Dr. Daljit Kaur, New Delhi. Nutshell take-home message from this session is two things. Yes, very important. CC, intratympanic decadron, and giving hearing aids in a very early stage in cases of endolymphatic hydrops. I would urge, please don't just give them hearing aids. They get irritated. The disease is still active. The recruitment is still on, and they get very, very unstable and rigid. There is a question from Aziz from Egypt who says, is endolymphatic hydrops present in all cases of Meniere's disease? Yes. Meniere's disease means idiopathic endolymphatic hydrops. Now, whether it is cochlear hydrops or vestibular hydrops is to be seen and done, but it is, yes, it is there. There is a question from Mr. Jahangir Ali, Mangalore. How low frequencies are more affected in Meniere's disease? I have told you. Dr. Raj Shekhar from Bellary. Why many times Meniere confused as just giddiness? I told you, my dear, please, this is the prodromal stage of Meniere's. This is the prodromal stage of Meniere's. We have to be very careful. If a patient comes to us in impending viral disease, viral fever, and he's saying, I have malaise and I have tiredness, even in cases of arthritis, you would understand, there is only just fleeting pain in the, so these prodromal signs we have to identify and see. Dr. Kashi Raj Gavali from Kathmandu, treatment. Sir, I have told about the treatment. In my opinion, all the treatment has to be given together. The drugs, the diuretics, the intratympanic decadron, because I told you, there is no way of knowing whether it is the excessive production of endolymph or the decreased secretion, the endolymphatic duct getting blocked. So there is no way. Most of the time we assume that it both, and I have seen myself that if you only give drugs and salt restriction and other things, 45% of my patients become all right. But when I give this battery of tests, including an intratympanic decadron, my results are almost 80 to 85%. There is Vellore. How long is the rehabilitation? Very helpful. We have to do rehabilitation in cases of situation where there is central compensation not occurring. We have to stop giving vestibular sedatives as early as possible so that cerebellum takes over and the central compensation is self-initiated. But nowadays we have very scientific way of doing that by the this thing. There is a question from Kolkata, Anuradha Bose. How long and what does where is that gone? Anuradha, how long and what does you give acidothor? We give Diamox. Yes, we give Diamox. She's from Kolkata, Aniruddha Bose. He or she, I don't know, I'm sorry if I'm this thing you. We give Diamox. We may start, if it is very severe, as twice a day, but then we give for once a day, 250 milligram. Depending upon it, maybe 2 weeks, 3 weeks. Sometimes they do complain of calf pain and weakness. Then we have to give them, potassium supplements like banana or coconut water, and they become all right. There is another Chaturjit Talukdar from Assam. Thank you, sir, for presentation. Sir, does piracetam help? Yes, definitely it helps. It can be given for a long time. Now we have combinations with piracetam in the form of Ginkgoba. That can also be given. That is very good. Chan Sui Chi from Singapore, can you repeat the drug therapy? Yes, drug therapy has drugs in the form of beta histine, beta wort. We have piracetam. It can be given up to a maximum of 1200 milligram twice a day for a long period of time. If we have associated vestibular migraine, we will have to give Diva or Sibelium for 3 to 6 months, along with the treatment of endolymphatic eye drops. If we have benign paroxysmal positional vertigo, we will have to do the repositioning exercises, and only then a complete this thing would be better. Abhinav Gupta from Aligarh, please explain basic intratympanic steroid total dose duration, how many? Yes, Abhinav, very important question. I think I wish I can take a webinar on intratympanic decadron alone. I don't put a Grommet. Because Grommet keeps coming out. We give it at different spots with a 55 millimeter, 26 gauge long needle. In the insulin syringe is about half a cc or even more, because the first time when you give, you don't know what is the capacity of the middle ear. There could be a very big mesotympanum, and all the drug might go there and not come into the area of this thing. So the first injection, you have to give a little more. Moment it fills up, stop it. Then turn the head to the same side so that it remains between the promontory and the posterior wall. That is the area where you want the drug to be there. So if you put your on the side of the disease of the injection, you have to tilt the head so that the promontory stops it from going into the station tube, and the station tube is higher, and it is like that. Yes, unfortunately, we don't have 16 milligram per ml decadron in our country. In America, you have 16 milligram. We only have 4 milligram per ml, and that is what we are going. The only thing is, Rama Subramaniam from Chennai says, fantastic presentation. Thank you very much. We'll come to that later, my dear friend. Dr. C. N. Nandyal from Kalaburgi, total bilateral vestibular loss. Is it real functional vestibular loss where habilitation exercises doesn't help? Does Meniere's disease end up as total vestibular loss? It can. We have known burnt out disease is a thing in Meniere's disease. You can have complete destruction of the vestibular system and the cochlear system, but then it keeps coming back. And that is the reason when you have bilateral loss and the patient comes back with vertigo and we have to give a gentamicin, we are generally, otherwise he can tell us the fullness in whichever side, he will still complain of fullness because fullness is like distension. You take too much of water, your stomach distends and you are uncomfortable. Similarly, these people also, the endolymph is in a closed cavity, it presses onto the walls of the otic capsule and leads to a pain, deep-seated pain or a headache. So you ask the patient which side is that, otherwise do a vamp and give intratympanic gentamicin on that side. So that is how you do. MV Apparao from Visakhapatnam, what is your opinion upon CHAMP? Yes, very good question. I like CHAMP, and particularly when there is only tinnitus and hearing loss or only tinnitus, and that means we have the problem in the pars inferior, and it may help, but as all these investigations are, the chances of false negative are also very high. But if it is positive, it is very good. Sejal from Daman, what is the dosage and protocol to give intratympanic? I've already told you. Dr. Rakhi Shankar Madurai, thank you, sir. Very informative. Thank you, my dear. Santosh Prasad Kesri, Gangtok. Sir, do you do glycero head test? No, I don't do. These are very invasive tests. Very dehydrating. I don't do that. Deepak Gupta, Varanasi, sir, what is the duration of dosage of beta-histine? Very good question. You can actually give it for very long. In the initial stages, when there is the stage 1 or the prodromic stage, I give paracetamol because see, it also increases your cerebral flow. So it is not a bad drug. It can be given, paracetamol can be given in children also. I don't give it in pregnancy, but otherwise I give it for long durations, depending upon at what stage the Meniere's disease is, and the results are seen to be very, very good. Yogesh from Erode, sir, in Meniere's role of paracetamol, I've already told you, sir. Vikram Oberoi, Delhi, what dose of intratympanic steroids? I've already told you. Karthik Palka from Mumbai, what is the dose of intratympanic? I think we'll have to take a webinar on intratympanic. This is a very good way of treating, I can tell you that. Vidya Sagar from Hyderabad, electrocochleographic identify the head drops. Yes, we do it here and we are very happy. And Dr. Sohag from Rampurahat, sir, please state the amount of dosage. I've already told you, it is the capacity of the biliary, the mesotympanum and the hypotympanum together. So it will be the first injection which will tell you how much to give, and subsequently you remember that in this patient I gave this much amount and in this patient I give this. Very important, if you give an intratympanic decadron and the patient has severe vertigo, that means the patient will definitely improve. That means the fluid is going, the decadron is going in the inner ear, it is getting absorbed there. Sometimes you have a false membrane, mucosal membrane over the round window. The absorption into the inner ear is not so good, but still it is much better than giving orally. Wasim Zulfikar from Oman says, is there any role of steroids in MT? Yes, oral steroids are given. Those people who don't give intratympanic should be given, as I told you, all the modalities. Steroid has a very big role in endolymphatic hydrops because we don't know what is the cause. Whether it is a blockage of the endolymphatic duct because of the inflammatory debris, we don't know, and that is the why. Or there is congestion of the stria vascularis. Steroids have very good role to play and very early improvement. Anil Thakral from Faridabad, how much is the dose of intratympanic I've given you, sir? Suryakant Nanded, sir, not commented about Cinnarizine. No, I have nothing. It is only as a vestibular sedative. It is better to give Meniere's when you're sure clinically. Give Betavert rather than Cinnarizine because at least it acts better and it acts at the place where we want. Dr. Pratyusha Guntur, how long intratympanic decadron? Very true. Again, I'm telling you, I have to have a webinar on intratympanic. I give continuously 10 days and some improve within 3 injections, 3 days. So please, sometimes I have to give twice a day. It totally depends upon which situation, which stage the patient is coming, and that's it is. Do I have time or I am surpassing the time, Mr. Naveen Kaul? Because there are many questions still there, many questions. I have 100 questions more. So what do you want me to do? Huh? Okay, yeah. Okay, then I'll continue. I will just miss the repetitions. Chingal Patu, thanks, a very good presentation. Pune, thank you, sir, very informative. Mangaluru, intratympanic, how often I have told Agra. This is Dr. Alka Singhal, Agra, role of vitamin D and B12. Very important, very important. These deficiencies are known to cause these diseases. And in our setup, we always give them. There is no problem. You can get the test done for their deficiencies. And if there are, please give them. But otherwise also, if you give them vitamin B12, keep giving for some time, then stop so that the toxicity doesn't occur. Alok Mandal, Kolkata, can we try methylprednisolone? Secondly, if ocular complaints comes with Diamox, should we stop Diamox? Yes, we have to. Whenever some people are very sensitive to Diamox, they say, I'm dying, as if I'll fall down. We can't help it. We have to go. And that is the reason why steroids in these stages are helpful. Amravati, how to taper beta-histine? Very good question. I give 48 milligrams Betavert for the first 1 week, then 24 milligram at bedtime next 1 week, and then stop it. Role of Pune treatment of Meniere's disease in pregnancy. Okay, that's a good. I would like to treat it with only intratympanic decadron. I have a patient coming to me. She was my patient earlier. Now she got pregnant. I'm not giving her any medicines. As I told you, I don't give piracetam also during pregnancy. I'm not sure. I don't want to give because the child is very important. So intratympanic decadron would beautifully help the symptoms go away just like that, because it has an effect on the stria vascularis. It has an effect on the endolymphatic duct. It has effect everywhere, and there is no problem. Mishawar from Hyderabad, can Deflacord replace dexamethasone? Yes, but the intratympanic is to be given decadron only. If you are giving orally, no problem, you can give Deflacord. Amravati, diuretics other than Diamox? No, we don't give. Diamox is a very specific diuretic for the ear and the eye. We have other diuretics like Lasix and other things for the kidney, but for ear, please understand, for ear and for glaucoma, Diamox is the best. You have to give that. Umesh K. Malhotra, Delhi, great to see you. Okay, that is a good presentation. Thank you, my dear. Very good question. Vilas Mishra, Lucknow. I saw a patient presenting me just hypercusis and the PTA relieved bilateral sensory loss with no vertigo or tinnitus. I required whether it was fluctuating, and I treated with him as a patient. Very good, very good. Believe you me, these patients would bless you. We keep diagnosing, we do a tympanometry, mild little negative pressure, and we start treating that, and we just forget about the inner ear causing this problem. Dr. Gurmeet from Balaghat, can Ginkoba? Yes, I'm giving a combination of piracetam and Ginkoba. It has definitely, if it is not doing anything, it is still a good, it's not a bad thing to do. Bashir Ahmed from Dhaka, what is the best approach for petrous apex cholesteatoma? Oh my God, this is not to do with this. We will tell you when we do about that. This is Meniere's disease. Kamal from Egypt says, thank you, sir. Did you insert grommets? No, I don't do. I give every time, and believe you me, every time an injection, it's just giving a small little with 26 gauge needle, long needle, 55 millimeters. No problem. By the time the next time this is healed completely, you can see the blood vessels. Try to go between the blood vessels so that you don't form a hematoma on the drum. So that is a very important thing to do. Nikita from Jammu, excellent presentation, sir. Do you educate patient for acute attack, and what do you explain? Oh yes, I tell you that's a very good question. I had a lady from England, London, coming to me. She was in the embassy here, and in the initial stages, she just would come. I would get the CC done. Later on, she came after 6 months and she just went and said, Dr. Hans, will you give me the injection? I said, no, CC, no, sir, I don't want. I'm getting the attack. Then after a year, she came and again told me injections, sir, 2 injections. The latent period of the disease kept increasing, and now for the last 5 years she has not come, and she has been sending me patients from all over the world. There is a Georgia Bakrana from Romania. Do you use high doses of beta-stine? Yes, 48 milligrams. They say beta word can be given up to 200 milligrams a day in acute cases of mania. So beta word 48, 3 times to 4 times a day. Yes, it is given. V. Manoharan from Chennai. Is any role of vitamin E, sir? Very good talk, sir. Yes, vitamin E, again, these are deficiency things. Metabolic, as I told you, deficiencies. Vitamin E, vitamin B12, vitamin D, all these deficiencies have to be, because they can produce any kind of disease in the body. Dr. Shantanu Bhattacharjee, Kolkata, opinion of platelet-rich plasmas in the treatment. No, sir. I have not tried. I will go through this, and if it is a good thing, we will definitely start here. But yes, there is a percentage of patients, 10 to 15, who have come very late, don't respond to anything. We just have to give gentamicin. We can try. Utpal Sarma from Assam, sir. Have you ever considered oral steroids? I used to give oral steroids, but since the time in the last 10 years, when I was in government, I didn't have these facilities of microscopes in my clinic, and I used to give oral, very good results. But then again, as I told you, we know there is a problem of vasoconstriction in the stria vascularis. How much of steroid is reaching there despite it causing all the problems most of the Indians are diabetic, they are hypertensive, they have acidity because of the food they take. So all this, whether we can give them steroids or not, so intratympanic steroids are the very good thing. Yeah, Nabeen from Kathmandu, what are your dietary advices to the patient? Very good. Sorry if I have forgotten. Low salt intake and low stress. Very difficult to say no stress, but low salt and low stress is the advice which I give. They have to change their lifestyle. It is a psychosomatic disorder, stress-induced disorder. We will have to change our lifestyle if we want to change the disease. It is like diabetes and blood pressure. If we don't change our lifestyle, don't take a walk, don't meditate, this disease is psychosomatic in nature and will keep coming back with vengeance. Thank you very much. There are many more questions, but almost the same. There is Arjun from Punjab saying, kindly take a webinar on intratympanic injection. Thank you. I would love to do that. Believe me, in the last 10 years, intratympanic for other cases, acute tinnitus, we have not diagnosed whether it is a cochlear hydrops. We have not got anything, just tinnitus, maybe noise induced, a temporary threshold shift. You give them intratympanic, sudden sensorineural hearing loss, vascular or viral, along with antiviral drugs and hyperbaric oxygen. Intratympanic is a great thing to do. There are many other cases. I think it's about 7:15. Naveen, there are about 50 more. If you want me to continue, or maybe we can have a second webinar.
Sir, as you wish. If you can, okay, another 7 minutes.
Okay. I can. V. Manoharan from Chennai, what is the duration of paracetamol? I've already said. Nabin from Kathmandu, what is your dietary? I've told you. Uh, Acha, Bhupendra from Jaipur is asking what is CC. I think um, maybe this is SI, short increment sensitivity index. He's asking for CC. No, it is not CC of the email CC. It is SI, short increment sensitivity index is uh, uh, to find out the recruitment in the cochlea. It tells us about that. Voda from Bucharest, Romania, prophylaxis of crisis. Prophylaxis of crisis, I have not understood the surgery. Sujit from Amravati says, what about role of benzodiazepines? I have not tried, G. Not tried. Ravi Jadhav from Hyderabad, role of MRI imaging in the diagnosis and treatment. No, yes, in diagnosis of associated things. If you have a small little lesion intracanaliculaire in the interaortic canal, it can happen. As I told you, there could be doing a secondary hydrops. We can see the vestibular hydrops in MRI, and that will tell us. But again, as I told you, no investigation can tell us whether it is increased formation of endolymph or less excretion of endolymph. That is not possible. And okay, very good question, Dr. Anil Jain from Bhopal. So, what is your youngest patient, what you have managed? If she has presented, thanks a lot for a wonderful presentation. Yes, in a very young people, less than 10 years, you will also have to keep a large vestibular aqueduct syndrome in mind. Vertigo in children have to be taken very, very seriously. And if they're coming with progressive hearing loss and dizziness, you will have to see that maybe they are suffering from a large vestibular aqueduct syndrome, but you can't do anything about it. A large vestibular aqueduct syndrome means just fold your heads and hands and sit down and let the child go to the inevitable and then do a cochlear implant. It is very, very difficult to stop this condition. By no means can you do that. It is just a coincidence. It's a finding which we know is going to lead to permanent hearing loss today or tomorrow, depending upon what is the size of the vestibular aqueduct. Yes, very small. I remember 21, 20, early 20s. I have seen many children coming in that. Stress is one of the most important things which is common to them. And stress is a very, very common thing which I've seen. And they present as high drops. There is one from Rahul Dake. Is there any YouTube videos of intra? Oh yes, plenty of them. Even my video is there, but you have intratympanic videos, and I will put a fresh one if you want and send it to you. Badrinath from Bangalore, what is the percentage of benefit from Menet's device? Okay, yes, we all know that the Menet's device, the vibrator, is trying to dislodge the debris from the endolymphatic duct. It does, but till you treat the cause, and the cause is, as I told you, allergic, autoimmune, and traumatic inflammatory debris, till you treat that, just giving the device doesn't help much. It doesn't help much. It doesn't help much. I think I can call it a day today. There are still many, but most of them are repetitions, and I can call it a day. Thank you, everybody. I'm so grateful to have all of you to be there. Thank you, Mr. Naveen Kaul, for giving me this opportunity. And I hope